Dr. Nagashri.
Good morning. I am Dr. Nagashri from Kidwa Institute of Oncology, Bangalore. Today here I am here to present segmentectomy for lung nodules, our experience in an oncology center in South India. Coming to segmentectomy data, it is seen only from Southeast Asian countries and UK and US after these two trials like CALGB and JCOG, that too for the primary lung cancers. Then what about the data from India? We don't have enough data from India. So often in our tertiary cancer center, we come across more metastatic lesions than early primary cancer. That too, oligometastatic lesions of lung are treated with curative intent. So because of sparse data, we aim to present our institutional experience with our pulmonary segmentectomies. Coming to materials and methods, it is a prospectively maintained data and it has been collected from January 2021 to March 2025. Included, all the patients who underwent segmentectomy were included. Those patients who underwent segmentectomy as a part of multi-organ resection were excluded. And the patients were taken into study after MDT discussion. They were evaluated for nutritional status, performance, pulmonary function test and cardiac evaluation and effect tolerance. And prehabilitation program was run with smoking cessation, nutritional rehabilitation and respiratory physiotherapy. Their CTs were evaluated with 2D CT and 3D reconstruction to map the lung nodules and segmental anatomy and determine the type of segmentectomy and surgical margins. These are the few of the segmentectomies which we have done in our center. And this is the CT scan where we use 3D reconstruction to determine the margin, initial parenchymal margin. Thereby we determine our bronchial section. Here in this case it is apical. So, and we go to in details of subsegmental artery and decide upon the resection of arteries and also the intersegmental vein. And thereby we plan our CT using both 2D and 3D CT. And intra, it is lung isolation using a double lumen tube with the patient in lateral decubitus. In open it is posterolateral thoracotomy, and in VATS we use a utility incision in the 4th intercostal space and a camera port in the 7th intercostal space. If it is upper lobe we are using 4th intercostal space. If it is lower lobe we are using in the 5th intercostal space, the posterolateral thoracotomy. And we start with identification of vessels followed by modified inflation deflation technique for the intersegmental plane identification and division of parenchyma along the ISP. We collected data on surgical approach, intraoperative parameters, postoperative outcomes, histopathology and oncological follow-up were analyzed. Coming to our results, the median age of presentation is 52 years and there were 17 females and 12 males and the median preoperative FEV1 was 66 and nodule size was around 2 cm. Coming to surgical procedures, we perform in these years we have performed around 172 lobectomies and 20 pneumonectomies and 29 segmentectomies. Among these, VATS resections were done in 12 patients and primary open resections were in 17 patients. This conversion to open surgery happened in 3 patients. 2 were due to bleeding, 1 was non-progressive. Coming to segmentectomies by proportion by lobe, upper lobe is the most common and right S1 is the most common segmentectomy being done. And the mean duration of surgery is 140 minutes and mean blood loss is 100 ml and patients were extubated on POD0 around 14 and 15 on POD1. ICD removal on day 3 and post-operative hemoptysis has been seen in around 11 patients, which is 37% is conservatively managed. And there is a aid leak in around 3 patients which has been managed with negative suction. There were no grade 3, grade 4 complications. Histopathologically, metastatic tumors are the most common, among which colorectal is high, and we operated around 4 cases early primary lung cancers. And we followed up the cases of which 29 patients, only 3 patients recurred, 1 within 2 years with bony mets, which was a primary lung cancer, and the other 2 were One is vaginal carcinoma metastasis and one is sarcomas. They recur within 3 to 6 months. Coming to discussion, our center performs almost around 60 to 70 lung tumor resections annually with a lobectomy to segmentectomy ratio of 6:1. So among segmentectomies, our right S1 segmentectomy is most frequently performed. We do segmentectomies mostly for metastasis. Coming to margin status, complications and Indian scenario of segmentectomy. In margin status, for a primary lung cancer, we need at least 2 centimeters or double the size of the lesion. But for metastasis of lung, R0 resection is our priority. So optimizing the margin with segmentectomy is feasible with preservation of parenchyma. And complications like hemoptysis is more in segmentectomy but can be managed conservatively. Even aid lead can be managed conservatively, and we didn't need any blood transfusions. Coming to Indian scenario, why is segmentectomy data sparse in India? This is because we don't have primary lung screening and we have less number of training centers and financial issues like lack of affordability for VATS, robotic and staplers. Coming to our conclusion, our findings add to the limited Indian literature on segmentectomy, highlighting its clinical significance. Most common indication for segmentectomy is metastasis than primary lung in Indian population. We can optimize margin in metastatectomy using segmentectomy, preserving parenchyma. Hemoptysis, although is the most common complication, can be managed conservatively. More studies focusing on segmental anatomy of lung in Indian population is the need of the hour. Our study lacked data on FEV1, which we couldn't collect due to various reasons, but larger studies are needed to assess feasibility and outcomes of segmentectomy in our Indian population. Thank you.
My name is Dr. Dayanand. I am from Kidwai. I am presenting data about mixed phenotypic acute leukemia, which is actually a real-world experience of mixed phenotypic acute leukemia, a retrospective analysis from a tertiary care institute. Introduction, mixed phenotypic acute leukemia, that is MPAL, is a rare and aggressive form of leukemia and which is characterized by absence of markers specific to the single hematopoietic lineage. When we come to there is a lack of comprehensive data on its clinical presentation, laboratory features, immunophenotype, cytogenetics and treatment outcomes. And the data regarding this in the clinical presentation, laboratory features is scarce. So there is a real gap in literature and awareness, and contributing even small data set can add value to this underrepresented area. So when you come to the aims, aim is to analyze the retrospective data of the MPAL to understand its clinical patterns and to improve the diagnosis and the guide the treatment strategies. So objectives, to describe the clinical profile of the MPAL patients and to assess the outcomes and including remission rates and survival, and also identify the prognostic factors influencing the outcomes in the case of MPAL. So it is a retrospective data, which data is collected over the period of 4 years, and we have inclusion criteria is patients above the age of 18 years with newly diagnosed MPAL. When you come to the data consisted of totally 29 patients, and there was no gender predominance observed. And median age at diagnosis was 37 years. Most of the patients belong to the age group between 19 to 30 years. And T-bar myeloid was the most common subtype. And when we see data available, B-bar myeloid is the most common type. In our study, it was T-bar myeloid was the most common type. And also molecular abnormality seen are BCR-ABL and FLT3 ITD. In some 16 patients, we could not do it. It was a negative in other 11 patients. So most common cytogenetic abnormality we found was translocation 922, which is whenever you see the data from the real world, it aligns with that. And clinical presentation, most common clinical presentation is fever with associated symptoms. And we saw bleeding as a clinical presentation in 3 patients. So when we come to the treatment, most other patients received modified BFM95 protocol, who are translocation 922 received TKI along with that. And one patient received hypomethylating agents, and some patients received steroid only because of the poor general condition. So day-8 blast clearance was seen in about 48% of the patients. And when you come to the outcome, bone marrow remission status was achieved in roughly 38% of the patients. And 48.3% of the patients succumbed during the treatment, indicating the aggressive nature of the disease. And when we see, when the patient achieves bone marrow remission, the number of patients alive is directly proportional to the bone marrow remission status. And also, whenever the patient achieves bone marrow in remission, the median overall survival is 16.7 months. When you come to the patients who did not achieve bone marrow remission, median survival was only 4.7 with a significant p-value. And also, we followed up the patients for roughly median follow-up was 4.37 months, and overall survival and progression-free survival was same, that is 17.85 months, indicating that there is a lack of availability of salvage regimens. So discussion, in the real world we see it is a more of bimodal presentation, that is around 19 years and around 60 years they present. In our study, most of the patients were adolescents and young adults. And also T-bar myeloid was most common in our study. In the available data it is B-bar myeloid. And also male predominance is seen, that was not observed in our study. And also PFS and OS overlap, that indicates the lack of salvage therapy for this disease. And also translocation 922 was the most common subtype, which aligned with the previous studies. And also median overall survival is 18 months, which also aligns with the previous studies. And as a response indicator, day 8 prednisolone response and end of induction bone marrow response status were significantly associated with overall survival, consistent with the observational studies, other studies. So conclusion, our study add values to the underrepresented area of MPAL, and also day 8 prednisolone response and also end of induction bone marrow remission status would be a practical approach for managing MPAL patients in resource limited settings. And also it directly correlates with overall survival and also PFS. And more prospective studies are required for to know more about the therapeutic approach and also identify variables capable of predicting outcome and guide to therapy. Thank you.
Yeah, good work. Just wanted to ask you a few things. Of your sample size of 29, all these were high-risk patients. So how many of them would you have planned for an upfront transplant with your high-risk patients?
So questions is not audible. So transplant patient who achieved bone marrow in remission, we have given a transplant option, sir. But
so in your study, I mean, in your patient subsets, for the 29, how many of them went on to get a transplant?
It's not active. So we have given option now for transplant to them, but due to the lack of funds, so we have not done, sir.
And why was most of the patients on a BFM protocol? Because what I saw was that B myeloid was your most common,
yes,
but you still used a BFM protocol in your patients. But you manage most of them like an ALL. Any specific reason for that?
So we have used modified BFM 95 protocol for uniformly for all of the patients, sir, except for one patient who had MPAL and flow cytometry, but he had inversion 16 cytogenetics wise. So for that patient only we have used HMA. For all other patients, we have used modified BFM 95.
All your deaths are due to disease or due to side effect? Is there a bifurcation? All the deaths reported now are due to disease progression or also maybe treatment related?
Yes, sir.
In all the deaths you reported, are they due to disease progression or also
So most of the cases it is due to the disease, and also some of the patients did not follow up, and the patient discontinued treatment, but most of the times it is the disease.
Good morning, respected judges. My name is Dr. Chetan. I'm from Kidwai Memorial Institute of Oncology. My study is a pilot study to evaluate the efficacy and safety of prophylactic administration of romiplostim to prevent grade 4 thrombocytopenia in myeloma and lymphoma patients undergoing autologous stem cell transplant. So we know that grade 4 thrombocytopenia is one of the dreaded complications of autologous stem cell transplant. According to CTCAE, it is less than 25,000 per deciliter. This pilot study aims to evaluate the safety and efficacy of prophylactic romiplostim in preventing grade 4 thrombocytopenia in this patient population. Primary objective is to evaluate the efficacy of prophylactic romiplostim to prevent grade 4 thrombocytopenia in this patient population. Secondary objective is to study the safety profile of romiplostim in this setting and to study the role of romiplostim in reducing platelet transfusion requirements and the effect on platelet engraftment, and to study the effect on duration of hospital stay and perform a cost-benefit analysis. So it was an open label pilot study. It included 26 patients, which were most of them were multiple myeloma and lymphoma patients undergoing autologous stem cell transplant. And the study period was from January 2024 to March 2025. So the eligibility criteria was adult patients who are more than or equal to 18 years old, who are multiple myeloma, plasma cell leukemia patients or lymphoma patients undergoing autologous stem cell transplant, and were willing for written informed consent. Patients less than 18 years old and who had previous hypersensitivity for TPO receptor agonists, history of thrombosis, pregnancy or breastfeeding, and not willing for consent, or patient with MODS and CIRS were excluded from the study. So those patients who met the eligibility criteria will undergo the transplant process, and post stem cell transfusion on day +1 they received romiplastim 250 micrograms subcutaneously and weekly till platelet engraftment. So baseline characteristics was recorded, daily CBC monitoring was done till platelet and neutrophil engraftment. STP transfusions were given according to the institutional protocol, and adverse events were monitored. So after this, there were two groups. One is the romiplastim group and the other is the historical control group, which did not receive romiplastim. So the data will be compared with these two groups. So baseline data, we had 40 control patients and 26 patients in the romiplastim group, 13 each of multiple myeloma and lymphoma in the romiplastim group, whereas 21 patients of multiple myeloma and 19 patients of lymphoma in the control group. So baseline characteristics including age, gender, prior lines of treatment and conditioning regimen were well matched between the two groups. And the average dose of romiplastim required was 2 doses of 250 micrograms subcutaneously. So incidence of grade 4 thrombocytopenia, according to the conditioning regimen used, there was significant decrease in the incidence of grade 4 thrombocytopenia in patients receiving melphalan 200 as a conditioning regimen. There was a trend towards decreasing incidence in the beam regimen patients, but the sample size in the M40 group was too less to draw meaningful conclusions. However, mean STP requirements was decreased in all three groups. We can see the bar chart showing decrease in mean STP requirements across all the regimens. When we come to neutrophil engraftment, platelet engraftment and duration of hospital stay, we can see there is significant, statistically significant faster platelet engraftment in the romiplastim group compared to the control group. But neutrophil engraftment and hospital duration of hospital stay was comparable. And when we look into the adverse events like thrombosis and bleeding, there were no major events in the romiplastim group. And we performed a cost-benefit analysis wherein we can see that there is significant cost reduction with using romiplastim in all the groups, but melphalan 200 had a significant cost reduction. So discussion in comparison to similar study conducted by Scordo et al., which found that romiplastim had a comparable median days of grade 4 thrombocytopenia or transfusion requirements, time to platelet engraftment. Our studies showed the trend towards reduced grade 4 thrombocytopenia in patients treated with melphalan 200 and beam, and lower mean STP requirements across all the regimens, and there was a faster platelet engraftment across all regimens. And there was a similar study where which our study aligns with the results from that study, wherein romiplastim group with multiple myeloma receiving melphalan 200, there also they had lower average STP transfusion requirement and faster engraftment. So conclusion is prophylactic romiplastim administration during autologous stem cell transplant is a safe, effective intervention in reducing grade 4 thrombocytopenia. However, larger studies are required to confirm these findings. Thank you.
Yeah, good presentation. Just wanted to ask a few things.
Yes, sir.
In your center, what was the incidence of grade 3, grade 4 thrombocytopenia during the time of your transplants?
Sir, as we saw in the control group, almost all patients had grade 4 thrombocytopenia, sir.
So did that require blood transfusion? So what is the threshold that you use for giving blood?
Sir, we usually see the trend. If it is dropping less than 20,000, we are transfusing, sir.
So you transfer less than 20,000?
Yes, sir.
So by using romiplastim, you were assuming that incidence of transfusions would come down without added toxicities, right? So this is a pilot study, well done. And so what is the disadvantage of using platelet transfusion?
Sir,
have you had adverse effects to platelet transfusion?
Sir, since we are using single donor platelets and it is irradiated. We have not had no transfusion reactions are noted till date. But there is always a risk of transfusion reaction while using STP transfusion. And in this setting, because we are using high dose chemotherapy, there is also risk of alloimmunization if it is not irradiated. So that is one of the issues.
So what disadvantage do you have by using romiplastin?
Romiplastin in this patient population.
Thrombosis, you have a high chance of thrombosis in these patients.
Yes, sir. But we were monitoring platelet counts daily. If it is crossing more than 50,000, we have not used romiplastin in that patient population.
So your median number of romiplastin doses was 1?
2 doses, sir. Average 2 doses.
So that is twice, one at the baseline and 1 week after that.
Sir?
One was at the baseline. Day 1 you had to give romiplastin.
Day plus one, yes,
Yeah,
sir. After
what is
that,
the median baseline platelet count in your study? Median baseline.
median
Platelet
baseline platelet count was 70,000, sir.
count. So before the transplant itself, your patients always had low platelet count.
Yes, sir.
So isn't that a confounding factor? Because when you take a patient for transplant, my understanding is that the platelets is usually above a normal level. So in your center, is it routine that your patients go for transplant with low platelets?
Sir, after giving melphalan or any conditioning regimen before days,
I'm asking baseline platelets before you start.
baseline before taking up for conditioning regimen, it is more than 1 lakh, sir, for all patients.
You don't have the mean or median of that.
That baseline currently we don't have, sir.
Yeah, good.
Thank you, sir.
I'll be presenting on the clinical outcomes and acute toxicity profile of radical radiotherapy in prostate carcinoma, a retrospective analysis. So prostate cancer remains one of the most common malignancies among men worldwide, with the combination of radical RT with ADT being the standard approach for treatment for intermediate and high-risk localized prostate cancer. Hyperfractionated RT have gained traction due to their radiobiological advantages and patient convenience. This study presents institutional data on clinical outcomes and acute and late toxicities associated with VMAT-based radiation for prostate cancer. So the objectives were to report the biochemical recurrence-free survival and overall survival associated with VMAT-based radiation for prostate cancer, and to report the acute and late toxicities associated with it. A retrospective analysis was conducted on 40 patients with histologically confirmed prostate cancer treated with radical RT, definitive or adjuvant, using VMAT between December 2020 and May 2025. All patients were treated with VMAT to the primary with or without pelvis as per the POP-RT trial or the CHIP trial along with daily CBCT. The patient population included were localized or locally advanced cases of prostate cancer, and patients with metastatic disease and history of prior pelvic RT were excluded. The follow-up period was patients were followed up regularly with serum prostate-specific antigen levels measured at 1 month post-RT and then 3 monthly. Acute and late toxicities were documented using the RTOG criteria, and the variables assessed were demographics and acute toxicities. So the different fractionations that we used were for 12 patients, 12 out of the 40 patients we used the fractionation 68 gray and 25 fractions, 60 gray and 20 fractions for 9, 36.25 gray and 5 fractions by SBRT for 6 patients, 76 gray and 38 fractions over 7.5 weeks of 8 patients, 66 gray and 33 fractions over 6.5 weeks of 4 patients, and 64 gray and 32 fractions over 6.5 weeks for 1 patient. Median age was 73 years. All of the tumors were adenocarcinomas, and most patients underwent neoadjuvant hormone therapy followed by definitive RT and ADT. It's 87.5% of the patients. And if node positive, pelvic nodal volume was treated with a dose of 50 gray and 25 fractions to the bilateral pelvic nodes. Out of the 40 patients, 25 received RT to the primary alone, and 15 received RT to primary and pelvis. So baseline characteristics, out of the 40 patients, 4 patients belong to stage 2A, 7 to stage 2B, 4 patients to stage 2C, 7 belong to stage 3A, 14 belong to stage 3B, and 4 belong to stage 4. N0 patients were 25, and stage N1 patients were 15. All of the patients were non-metastatic, and high-risk patients, number of patients were 30 out of 40, and intermediate risk patients were 10 out of 40. The median PSA diagnosis was found to be 30.85, median PSA nadir value being 0.16. One of the 40 patients developed a PSA rise during follow-up, and one developed distant metastasis after treatment. At a median follow-up of 17 months, 39 out of the 40 patients achieved a complete biochemical response, and one patient who developed skeletal metastasis at 6 months post-treatment had a rise in serum PSA levels from baseline. So these were the survival curves. So the overall survival at 3 years was found to be 92.9%, and the biochemical recurrence-free survival at 1 year was found to be 96.8% according to the data. Coming to the acute toxicities, they were graded according to the RTOG criteria. The grade 1 to grade 2 gastrointestinal toxicity occurred in 25 patients, and grade 1 to 2 genitourinary toxicity was seen in 45% of the patients. Coming to late toxicities, Grade 1 radiation cystitis occurred in one patient, that is 2.85%. Grade 1 radiation proctitis also occurred in 2.85% of the patients, and grade 3 radiation proctitis also occurred in 2.85% of the patients. So to conclude, VMAT-based hyperfractionated RT in prostate cancer offers promising early biochemical control with acceptable toxicity. Hyperfractionated RT in prostate cancer is safe and feasible and is tolerated well with favorable biochemical control. Acute toxicities are found to be low and manageable, and longer follow-up is needed in our cohort to assess for the late toxicities. Thank you.
Good evening. I'm Dr. Raisa from Zuleika Institute of Oncology. I'm a first-year resident. Today I'll be presenting a retrospective evaluation of survival outcomes after definitive chemoradiotherapy with hybrid technique for locally advanced esophageal squamous cell carcinoma. So the management of Indian esophageal cancer poses a challenging conundrum due to the higher proportion of squamous cell carcinomas in our population as compared to adenocarcinomas in the Western population. Our patients also present in advanced stages, stage 3 and stage 4, and we see patients more often in a nutritionally challenged population. The optimal management involves striking a balance between the adequate local control of definitive chemotherapy, radiotherapy, and a satisfactorily low morbidity and mortality. The morbidity and mortality in definitive chemoradiotherapy usually includes toxicities to the organs at risk, which is cardiac toxicities, which manifest as pericarditis at the 2-year mark, and lung toxicities, which usually manifest as radiation-induced pneumonitis. Trimodality treatment, as well as dose escalation chemoradiotherapy treatment, comes with their fair share of pros and cons, and their cons manifest as a reduction in survival. As per the RTOG 9504 guidelines, they said that there was no improvement in dose escalation in the survival rate in dose escalation beyond 50.4 gray. However, the main criticism for this trial was that it was done, then most of the patients expired before dose escalation, and the modern guidelines of contouring and treatment planning was not followed. So our main objective was to assess the survival in locally advanced squamous cell carcinoma of the esophagus receiving definitive chemoradiotherapy. And our secondary objective was to assess the effect of cardiac and lung dosimetry in survival in patients receiving hybrid plans. Materials, we retrospectively analyzed 35 patients over a 2-year period with locally advanced squamous cell carcinoma of the esophagus. All received hybrid radiotherapy plans of VMAT and conformational radiotherapy, 3D CRT, adhering to the Quantec guidelines. They received a radiation dose of up to 59.4 gray and 33 fractions with a EQD2 of 57.92 gray and a BED of 77.2 gray, considering the alpha by beta ratio in esophageal cancer is 6. Patients deemed fit by the Multidisciplinary Tumor Board receive weekly concurrent platinum-based chemotherapy of cisplatin or carboplatin, and the initial tumor length was recorded via upper GI scopy. Staging was done on the basis of contrast-enhanced CT scans, and dosimetric data was recorded using a dose volume histogram. We recorded total dose, primary tumor volume, dose received by 95% of the PTV, mean cardiac dose, heart volume receiving 26 gray, lung volumes receiving 5 gray, 10 gray, 20 gray, and 45 gray, and the mean lung dose. Our 2-year overall survival was calculated from the date of registration, and survival analysis was performed using the Kaplan-Meier method, and correlation was performed between the dosimetric parameters and the survival using the Pearson's correlational formula, and two-tail significance of P was less than 0.005. So our results, we analyzed 35 patients, of which 17 were female and 18 were male. Our median age was of 62 years, maximum 80 years, and a minimum of 41 years. Dysphagia grading as per the guidelines, 31 patients presented with grade 2 dysphagia and 4 had grade 3 dysphagia to solids, semi-solids, and liquids. As per our upper GI scopy findings, 14.2% had cervical esophageal cancer and 75.8% had thoracic esophageal cancers, of which 9 were in the lower one-third, 56.6 were in the middle one-third, and 13.3 were in the upper one-third. All patients were cases of biopsy-proven squamous cell carcinoma. As per the CT scan, our staging, 45.7% were in the T3 stage, and only one case was T4. The total tumor length was calculated, and our mean tumor length was 6.9 centimeters with a standard deviation of 2.1. As per our dosimetric analysis, our primary tumor volume treated was 400 cc, and there was a weak negative correlation between the months in survival and the PTV, and a weak negative correlation between the PTV and the overall survival, as well as the tumor length and survival. As per our cardiac dosimetry, the volume of the heart receiving 26 Gray also had a weak negative correlation with survival. In our lung dosimetry, we found the mean lung dose had a significant negative correlation with survival. At 20 Gray, there was an insignificant negative correlation, but at lower doses of 10 Gray and 5 Gray, both the total lung and individual lungs had a significant negative correlation with survival. So we plotted our survival with the Kaplan-Meier curve, and our 1-year survival was found to be 64% with a median follow-up rate of 18 months. So our study population paints a picture of a locally advanced case with poor nutritional status due to dysphagia. Our 1-year survival achieved a definitive receiving definitive chemoradiotherapy was 64% survival, and there was a significant negative correlation between the lung dose of V5 and V10, indicating that low dose sparing of the lung is an important factor to be considered, which can be achieved by hybrid planning. So our conclusion is normal tissue sparing within the contact guideline limits can be achieved by hybrid plans, which allows for dose-escalated definitive radiotherapy to have a survival benefit.
Good morning, respected judges and attendees. I'm Dr. Siddharth Satishman from the Department of KMC Manipal. I'll be presenting our study on the early integration of palliative care with standard oncological care for lung cancer compared to standard oncological care, a systematic review and meta-analysis. The 2000 to 2016 SEER data shows that the 5-year survival is 59% for localized stage cancer, while it gets lower for advanced stages. The lower one is the GlobalCan projected outcomes, the million deaths that would occur by the year of 2050. If we surmise a 3% increase, there will be 8 million deaths by 2050. Early palliative care is very important for the timely assessment, treatment, effective coping, improved communication, support for decision making. There is randomized evidence that has shown that enhanced quality of life and symptom burden is seen across head, neck, GI, and lung cancers. Few studies from India. Some have shown impact, some have not shown impact. One meta-analysis on early palliative care has shown improved quality of life, but no effect on mood or symptom control. Our research question is to find the effectiveness of early integration of palliative care. We formed the question using the PICO framework. Our population is lung cancer of all stages, including all age, comorbidities, and symptoms. Our intervention is the integration of the early palliative care within 8 weeks of diagnosis or later, and seeing the various components of palliative care, comparing to the standard oncological management, while the outcomes we're looking are at quality of life, symptom burden control, overall survival, the advanced care plan documentation, aggressive interventions, the last month of life, and cost. Our objective is to ascertain the improvement in patient outcomes, which are symptom burden control, quality of life, overall survival, when early palliative care is integrated. And our secondary objectives are to see the advanced care plan, aggressive interventions in the last month, and cost. Our inclusion is all randomized control trials that have been empirically researched and reported in English on patients of lung cancer of all stages, who have the intervention being integration of early palliative care, and the comparator being standard oncological management. Our information sources over here are displayed here. Our Prospero registered protocol included the population of the search strategy using these following mesh terms and keywords, which have been divided as for population, intervention, outcome, and study design. Our search was done on the 15th of June 2024. The concepts were lung cancer, palliative care, treatment, outcome, study design. These were the hits that we had gotten among all the participants that had searched, while our final search string numbers are as follows. This is the Prisma chart of our search. We were in the end 3,273 articles that we narrowed down to. After removal of duplicates, about 2,000. After doing title and abstract screening, 65 articles. In the end, in our meta-analysis, we include 7 articles, while the other articles were excluded and were reported by narrative synthesis.
This is the population characteristics of all the studies. There are 7 studies in total. The 2 studies done in 2010 and 2017. There is a secondary analysis by them for the cost. All of them included metastatic cancers. Only one study by Datta et al. Included only non-metastatic cancers. Comorbidities were reported by 4 of them. 3 of them had not reported them. The intervention was early palliative care. Most of them introduced it within 3 weeks of starting. The other ones were milestone communication approach, the chronic care model, the EVOM model, which introduced incorporation of cultural aspects for the population of people in the country of China. The number of participants were comparable in both groups. Presenting symptoms were not reported by any of the trials. The landmark study by Tamil et al. Introduced the definition of time since diagnosis to be less than 8 weeks. That's what all of these studies have done. We did a meta-analysis using the forest plot. The HADS anxiety subscale showed no significant pool effect as the line of unity was crossed. The HADS depression subscale showed a significant effect favoring early palliative care. Symptom control was better for early palliative care. Distress thermometer score was not significant. The FACT lung for the lungs have specifically favored early palliative care, while the FACT general did not favor early palliative care. Trial outcome index did favor early palliative care. Cost analysis could not be done because raw values were not available. Mean survival was computed using this online tool, and it favored early palliative care. Advanced care plan also favored early palliative care. Only the aggressive interventions, the last month, was reported by one study which favored early palliative care. The risk of bias assessment was done according to these 5 domains, and there was high risk of bias in 4 studies. For QL, high risk of bias for 4 studies. For overall survival, some risk of bias for aggressive care plan, aggressive intervention, and cost. The grading of the certainty of assessment was done. It ranged from very low to low. Moderate was for the distress thermometer score, where it was low for all the others. There is an improvement in quality of life, symptom burden, and a modest reduction in aggressive intervention. Aggressive intervention was only reported by one study. Subgroup analysis could not be done because there were not a uniform distribution of reports. Cost analysis was only done by one, which showed a reduction in the mean total cost per day. Our conclusion is that this is a comprehensive meta-analysis that has shown an improved survival with a mean difference score of 4.27, reduced symptom burden, and improved quality of life. The limitations are that there are singular studies for the outcomes. They were not certified by the lung cancer stage, and observational cohorts were not assessed. These are the references. Thank you.
Very good job. Just exceeded the time. That's the only thing. So the final was all linked to lung, right? If I get it right, in
all
between
the population was lung,
all linked to lung. And so why don't you go for a formal publication of this? Because you've done enough systematic review and meta-analysis.
I didn't understand.
You should send it for formal publication.
Yes, we are planning to do that. So, yeah.
Thank you.
Just a query. Why palliation? You included all stages, right?
Sorry, sir?
You included all stages. I mean, even early lung cancers.
Yes, lung cancer, the most commonly taken population is metastatic lung cancer because palliative care is done in them. Early palliative care integration, which that definition is not done by concept in early stages of lung cancer at all, though it's shown improvement in survival when you've done it in early lung cancer. But it's not been attempted in literature. No studies have done that except one study. Except one Indian study, nobody else has done it yet.
No, but why would you want to integrate early lung cancer in the palliatives?
It is shown better quality of life till the end of their life, till the end of life care. EOLC is given to all metastatic lung cancers, mostly all cancers. Till that end point, the quality of life, symptom control is way better in all of them. So there's one study showing improvement in cost as well. So overall, if you integrate it well...
What are you palliating? I mean, I don't get, what are you palliating in early lung cancer?
No, the palliation is in the form of physical symptoms, quality of life, making advanced care plan, not only physical, sir. It's psychosocial, physical well-being, mental well-being, everything. It's not only symptoms.
Yeah, so the question that was asked was, what is the role of palliative care in early stage malignancies? So the NCC and all recommend for you to start palliative care right at the diagnosis, irrespective of your stage. Palliative care is not just for stage 4 patients. It includes every patient who's cancer, who's symptomatic.
Right.
So that's the overall outcome of looking at palliative care. It's just not stage 4.
Right.
Yeah, so there's a good study. Good luck.
Thank you.
Yeah.
Good morning, everyone. My topic is on clinico-pathological and demographic spectrum of colorectal cancer in a tertiary care center in South India. So it is the third most common cancer worldwide, one of the leading causes for morbidity and mortality. Initially, the incidence was higher in the Western population. Now it is slowly changing because of the food and the environmental changes. And mainly it appears sporadically, though genetic plays an important role. And it follows a well-defined adenoma-carcinoma sequence. So the recognized risk factors, which include but not limited to age and presence of inflammatory bowel disease and other family histories. Now the lower incidence rate is changing because of the environmental and genetic and the food habits. So the data regarding demography and clinical characteristics are incomplete in our Indian population. So we thought we'll do a study with the objectives of clinical and pathological features, social and demographic features, and the effect of gender, and the clinical and pathological differences among the colon and rectal cancer in our tertiary care center. It was a retrospective cross-sectional study from the database collected between Jan 2021 to February 2025. And those patients with incomplete records were excluded. And all the details such as the age, gender, religion, literacy, as well as the tumor characteristics with regards to location, histology, and stage of presentation were recorded. So age we classified as 45 and above as normal onset, and for the study purposes below 55 as young or early onset. And location, colon and rectum, in colon right and left, and rectosigmoid tumors classified as rectal tumors for study purposes. And the histology and the patient demographics, which include gender, location, differentiation, signet and mucinous morphology, and as well as staging, and followed by statistical analysis. So our sample size was 831 with mean age of 52.74 and 57.8% of males, with the literacy majority being illiterate. And the religion and the state of residence demography were also collected. And the tumor characteristics, we had majority rectal tumor 64%, followed by colonic, of which right-sided more common than the left-sided, with the predominant histopathology, adenocarcinoma not otherwise specified, followed by mucinous and signet ring cells. And it was moderately differentiated, the majority of the population. With the TNM staging, the T stage at presentation was T3 as majority with 64.9% with N plus disease. And stage 3 according to AJCC classification. With regards to gender-based characteristics, the rectal tumors are again more common among the male and female. Again, with regards to the colonic tumors, the right-sided more common than the left. And the histology, as you can see, adenocarcinoma was the majority in both male and females, followed by mucinous and signet ring cells. And differentiation, like I said earlier, both male and female, it was moderately differentiated adenocarcinoma being the majority. So here again you can see the T stage at the presentation was T3 and T4 being the majority with N plus disease. And with regards to the colon versus rectum comparison, again the moderately differentiated adenocarcinoma was the majority, with rectum being the most common than the colonic counterpart, followed by mucinous and signet ring cells, with moderately differentiated adenocarcinoma being the majority, and presentation of T3, T4 stage. So it was total of 831 patients with the mean age was 52.74, of which 57.8% were male, and the rectal cancers accounted to 64%, and the most common histology being moderately differentiated adenocarcinoma, followed by mucinous and signet ring cells with 11.4 and 7.6%. And 58 presented with stage 3. And women were found to have a higher T stage at diagnosis. And there was also an increased rate of illiteracy among women population. And one point to be mentioned is colon cancers were more likely to be of mucinous than the rectal. So we analyzed patient demographics, gender, tumor based on the tumor's location, and increasing age, which was a key etiological factor, with increase in twofold every 5 years. So it indicates a screening initiative will be required. The general studies, the mean age was 55 to 70, but our study it was 52.7, which indicates a slightly lower age at the time of diagnosis. And the rectal cancers having a higher incidence. And this, as I said earlier, moderately differential adenocarcinoma, followed by mucinous and signet ring cells. So from our study, there is an young population presenting at an advanced stage with illiteracy and due to lack of early screening program. So a nationwide screening program will be required to pick up those patients and start early treatment. Thank you.
Judges, please note, Dr. Sandeep has gone way beyond the time limit. I invite candidate number 2, Dr. Karthikeyan. This will be the last presentation.
Good morning, esteemed faculty. Hereby we present our data of colorectal cancer trends in the younger versus older population and tertiary cancer analysis. And colorectal cancer traditionally was considered as a disease of the elderly, but with with the rising change in culture as well as the food habits, there is noticed a rising incidence in the younger population globally, and it's alarming to know that the Indian population is also trending towards that. It could probably be owed to the Western culture influence on the diet as well as the patient's sedentary life with the change of workaholics. And aim of the study to study the clinical and pathological differences between the young as well as the older colorectal cancer patients. The objective was to find the relationship between the age and the tumor location, age and tumor histology, age and stage of presentation, as well as the gender predilection. This was a retrospective cross-sectional analysis at the Kidwai Memorial Institute of Oncology, and which included all the histologically confirmed colorectal cancer except for recurrent cancers and incomplete data. And the age group was divided into less than 45 years and more than 45 years. And the tumor location was classified as either right-sided colon or left-sided colon. The staging was as per AJCC 8th edition. And it was calculated with the chi-square test as well as T-stage using SPSS software. Patient characteristics, a total of 964 patients were analyzed, and the mean age was 52 years, and patients less than 45 were 28.8. That is alarming. And the males had a slightly more predilection at 58.9%. In the tumor characteristics, as we see, the rectal tumors were more predominant than the colon patients, probably because of referral bias. And histologically, as well as adenocarcinoma was the most common type, and mucinous carcinoma and signet ring carcinoma was 10 and 8.7% respectively. Well differentiated was 5.3%, moderately was more common at 74, and poorly differentiated at 20%. T stage was more in the later stages, that is T3 and T4 were 84%, and metastasis was seen in 25.5% at presentation. And the comparison between less than 45 years and more than 45 years is the main objective of our study. And the end results were mucinous subtype was seen in 16% of the younger age group versus 8.8%, almost twice in younger population. And signet cell was 15.8% in the younger population and 5.8% in the elder population. And poorly differentiated carcinoma was seen in 35% as in the younger population and 14% in the elder population. And advanced T3 and T4 stages 89% versus 82%, and nodal positivity was 89.9% versus 81%, and metastasis was also more common. All of these were statistically significant. And as we said, mucinous carcinoma was found to be almost twice as common, signet cell carcinoma as twice as common, thrice as common. It was seen 15%. And T3 and T4 was also more common. So histological subtypes, the mucinous and signet cells were almost twice and thrice respectively. And tumor characteristics, the advanced T stage was more common as well as poorly differentiated was also more common. And comparing the colonic versus rectal malignancies, the mucinous type was more commonly seen in the colonic type, especially on the right side, and highly poor differentiated cancer was also seen in the colonic malignancies. And there was no significant difference in the stage of presentation was colonic versus rectal cancers. And discuss the young onset colorectal cancer is increasing in presentation, that should be noted, and the higher rates of poorly histology and advanced stage and metastasis is common in the young. This calls for a tailored screening and early detection of malignancies, also to notify and to take on any minor complaints in the colorectal symptoms and start screening earlier age group. And this needs further research into etiology and management of these cases, especially because the younger patients tend to tolerate treatment better than the elder counterparts. So even though they present as an advanced stage, they can tolerate better aggressive treatment so that we can tailor their treatment accordingly. Thank you.
How does your data compare with the worldwide literature?
The global data, sir.
Yes, with the
So
global
the
data.
global data, initially, like 5 years to 10 years back, the Indian data was comparatively less in the younger population and more in the Western population. Now it's on par with the global data that young age group cancers are on par with the world data, sir.
What's the definition of AYA that you used?
Excuse me, sir?
What's the definition of AYA that you used?
AYA.
What is AYA?
More than 18 years up till 45 years, sir.
So, what I wanted to ask is that you've got a lot of data. How come you do not analyze the treatment or the outcomes of these patients?
I'm not, yeah.
You've collected around 800 odd patients and 280 odd patients with young patients with cancer. Both your colleague and you have not analyzed the survival outcomes or the treatments of any of these patients.
This was not a prospective study, so we need more prospective studies.
You don't need prospective. Just retrospective numbers are good.
Yes.
So how come you have not analyzed the survival outcomes or the treatment outcomes, or what treatment was given, how many of them got what treatment? That's not been analyzed.
Yes, sir.
So that would be very good. I mean, your large database,
Yes, sir.
to see the outcomes of these patients will be more important in an oncological side.
You're working on a paper as well on
Good.
that, sir. Thank you, sir.
That brings us to the end of the first session. I thank Dr. Ashwin Phillips, Dr. Hemant, and Dr. Trinanjan Basu for judging the session. Due to the delay in starting, we'll be proceeding in the next session. I invite Dr. Alfonso for the moderation of that. Thank you.